I think the first would be when we talk about limited stage small cell lung cancer. So basically, patients, when they have the disease early on in the limited stage or like stages between 1 to 3 small cell lung cancer, that's the time when you want to really optimize treatment compared to waiting until it's extensive stage or metastatic small cell lung cancer. So in that specific abstract, which was presented in the plenary session, patients who received durvalumab as a consolidation, which is treatment after having the concomitant chemoradiation, basically they did much better, and they had the greatest benefit in terms of overall survival and progression-free survival compared to patients who just had the standard of care of concomitant chemoradiation alone without the addition of the checkpoint inhibitor, the immune checkpoint inhibitor. I would say that that is, of course, practice changing. But not only that, it's a really a point where we want to really explore more and look more into this type of disease, and also make sure that we have the lung cancer screening program so that patients can have their disease detected early on in the earlier stages rather than wait until it's metastatic for small cell lung cancer. The second one, as you mentioned, was basically about brain metastasis. So I do believe that small cell lung cancer basically one of the major poor prognostications are when it becomes having like brain metastasis. So early on, when we do the MRI for the brain, if there are smaller lesions between 1 to 10 brain metastasis, if they're treating with stereotactic radiation, SRS, basically between 1 to 10, looks like it's beneficial to receive the local treatment. That's the first. And the second abstract also is tarlatamab. It seems to also control the disease well in patients with small cell lung cancer and brain metastasis when it's used as a subsequent line of therapy. So these were, I think, major important points to take back from ASCO. I just wanted to add as well, even though it's not practice changing yet, but basically, a lot of studies now emphasize the role of phase one or novel therapies in patients with small cell lung cancer or other disease categories, of course. Basically, novel agents that we looked at. Like CES6 inhibitor ADC or other novel agents, even though it's a phase one study, but it did show, even though it's a small number, like 22 patients, but it still showed that this patient population can have more than 60% response rate as a subsequent line therapy, even in patients with platinum resistant disease. So this means that phase one studies should be included into the multidisciplinary approach discussion of patients, because those novel agents, if incorporated early, can also lead to benefits for patients who don't have other options, or even to consider if they have a strong scientific rationale.